Hi, my name is Mackay Michael, and I'm a clinician by training, but currently working as a clinical research associate at Newcastle University as part of the CANDU project. And quick advertisement, because it did come up yesterday, but the CANDU project, which I'm working on at the moment, is seeking to develop an optogenetic brain implant for closed-loop control of epilepsy, aiming towards a first-in-man trial in the next 3 to 4 years. So if anyone's interested in that, you can find me over my poster, and I will more than happily talk to you about it, but that's not what I'm going to talk to today. Instead, I'm going to talk about a project we're working on at the moment, looking at seizure self-prediction in epilepsy. And this is a bit of a controversial topic because it faces sort of a bit of a contradiction at the heart of epilepsy, which is that subjectively, seizures are considered to be inherently unpredictable, striking patients out the blue, and that's why there's legal and social ramifications to the disease. But at the same time, there's a widely held belief among patients that they are to some extent able to predict their seizures. And in fairness, there's a whole range of subjective phenomena which we think may be triggering this belief. The seizure aura, in fairness, we sort of ignore because it's probably part of the ictal event anyway, but patients very widely report premonitory symptoms like prodromes or triggers to their epilepsy, which in reality, if they are preceding seizures, are giving us a bit of predictive information. And we think this is a worthwhile avenue to pursue because seizure prediction is a very hot topic at the moment, but a lot of the efforts focused on actually trying to predict a seizure happening at the time and trying to give patients sort of an imminent warning with some reliable predictive marker. But I think that sort of runs slap bang into clinical reality, which is that patients, by and large, they don't even comply very well with their own seizure medication, and expecting them to wander around wearing headgear and galvanic skin conductance electrodes and heart rate monitors and accelerometers is a bit of a big ask, particularly when the accuracy that such prediction gives isn't that great. But there's a whole host of subjective information here which is actually very easy to obtain from patients. And if you sort of have a look at the literature, it actually seems that patients are actually more capable than we imagine at actually predicting when their seizure is going to occur. And we can actually sort of resolve the inherent contradiction by saying that there's no evidence for any sort of subjective herald for a seizure imminently occurring. So no patients really, is there any reliable evidence that they know when a seizure is going to occur, they can do something about it. So they do strike out the blue. But actually, patients are remarkably good at knowing what their seizure risk is and are able to sort of quite reliably say days that have a high seizure risk and days that have a low seizure risk. And over a long period of time, patients are no doubt becoming aware of this, and that's why they think they've got some ability to predict their seizures. And that information is quite useful because actually what's happening is that the studies done in it sort of show that seizure risk fluctuates with things like self-reported anxiety, stress, sleep deprivation, prodromal symptoms, and all of this allows sort of a quite reasonable approximation of seizure risk over a window of sort of 4 to 6 hours. So rather than giving a patient a warning that you're about to have a seizure and getting it wrong most of the time, actually what you're doing is giving them a window in which they can potentially manipulate their medication to either improve seizure control over the next 4 to 6 hours if they're at high risk, or even ease off on their anti-epileptic medications and reduce their side effect profile if they're at low risk. But what's interesting about this is patients have sort of this intrinsic awareness of their seizure risk. And a lot of the things which co-vary with it are related to mood disorders. So a lot of the prodromes they get are anxiety, stress, irritability, changes in mood, or just being in a bad mood in general. And all of these sort of lead to higher seizure risk. And obviously mood disorders and epilepsy are well known to co-vary. This goes back as far as Hippocrates, who noticed the bidirectional relationship between people who suffer from depression and people who suffer from epilepsy. And it sort of suggests that there's an underlying pathogenic mechanism. This has sort of been in the literature for a while. And when we started recognizing the relationship between ictogenesis and mood disorders as well, we started thinking that, well, actually, maybe there is even a shorter term underlying mechanism which is precipitating both things like anxiety, stress, and mood disorders in patients, as well as an increased seizure risk, and patients are subjectively picking up on this and can do something about it. And the obvious candidate is cortical inhibition, which is disorders in the excitatory inhibitory balance as well implicated in epilepsy, but are also implicated in a wide range of psychiatric disorders. And it just so happens that there's a relatively easy visual psychophysics test called a TADIN test, which can actually probe cortical inhibition, which is just a moving sinusoidal grating, which looks at inhibition in occipital cortex. And what we're developing is an app which will bring it all together to let patients have a seizure diary, run a simple visual psychophysics test, prompt the users to do a mood questionnaire over time, hand it out to patients' epilepsy clinic, and see if over a length of time we can start predicting whether these patients are going to have seizures and see if we can see any fluctuations in cortical inhibition which link to seizure risk and mood disturbances. And that's it.